Olá, boa tarde a todos. I just welcome you in Portuguese, my mother language. I'm sorry about my English. And we are going to start our webinar about infections and lymphedema. This webinar is very important for us as patients, and we as patient advocates prepared it with the concerns and the worries that patients have about this subject, infections and lymphedema. This webinar will be recorded, and any questions, please do ask them on the chat box. We have a team on the back office, and if you have any technical problems, please contact us. This webinar will contains medical images. Please pay attention to that. And I'm going to present the presenters and the authors. And Pernille Henriksen is my colleague. She is a European patient advocate. She is the co-chair of our group, the VASCERN Primary and Pediatric Lymphedema group. And she is also a board member of DALIFU, the Danish Association for Patients. She came from Denmark. I'm Manuela Lourenço Marques. I came from Portugal. And I am also a European patient advocate and deputy co-chair in this group. And I'm also the chair of the Association and Lympha in my country, Portugal, an association for lymphatic disorders. And both of us are primary lymphedema. With us, we have the clinicians, and they are the presenters. And it is Dr. Tanja Planinšek Ručigaj. She comes from Slovenia. She is a high teacher in the university. She's the member of the Council of the Association of Vascular Disease, and she is the vice president in Slovenia of Lymphology Society. And Dr. Kirsten van Duinen, she comes from Holland. Our agenda will be, I'm going to explain a little bit what is VASCERN. We are going to listen to about lymphedema and also about cellulitis or erysipelas, infections, risk factors, treatments, and so on. And afterwards, we are going to have a testimony and a take-home message, and of course, all the questions that we are going to make it. We are going to try to answer to all of them. Okay, so shall we start? I'm going to explain you what is VASCERN, and VASCERN is a European reference network on rare and multisystemic vascular disease, and includes rare disease low prevalence and complex disorders, and involve multisystemic consequences. And our European reference network chosen 3 main goals, and we have every year the goals. They realize the potential European cooperation regarding specialized healthcare and reinforce research, encourage and development quality and safety benchmarks. We are a group very, very based on the European advocacy groups, and we have 5 working groups on our European reference network. With us, we have 70 organizations from patient organizations across the Europe, and also 26 providers, healthcare providers, full members, and plus 7 affiliated partners coming from 11 countries in the European Union. We are in this group, which is the Pediatric and Primary Lymphedema group. And VASCERN is a very large team working for rare vascular disease. In our group, we have 6 primary healthcare providers and 1 affiliate partner, and we also the co-chairs, and we work together trying to do our best for our illness. Of course, during this time, we just work in webinars because COVID, it's like that. And about our European patient advocacy and the community members, it's not only me and Pernille that are working on it. We also have 3 colleagues from Holland, from Italy, and from Germany, and also with the committee members that give us the input as well from the other countries with the lymphatic problems, lymphedema problems. We have quite a lot of work to do. It's not easy, not only for our group, but of all the groups. We work as volunteers, and we have very, very hard group for trying to search for answers for our illnesses. Now I'm going to leave you with Dr. Kirsten van Duinen. She came from Holland, as I told you before, and she is specialized in lymphology for children and adults, and also in phlebology. So please, doctor, just let you speak about it. Thank you very much for your time.
Well, Manuela, thank you for introducing me and all the others. And I want to thank all my colleague Tanja Ručigaj and also Pernille for making this presentation. So I'm very happy that you're all there, and I hope this will give you more information about cellulitis and the infections with lymphedema. And are there still questions? Then we can go to that afterwards. So, sorry, it's not this. Okay. So we'll start. So what is cellulitis of erysipelas? It's the most common infection in lymphedema, and it's a bacterial infection which is in the skin and subcutaneous tissue. So we see an overview of the skin here in this picture, and the E stands for epidermis, and that's the first part of the skin. Then have the lower part, the D for dermis, and there's also the vessels and the hairs, and the lower part is the subcutaneous part, and there's the fat cells. So what do we talk about? Do we say cellulitis or erysipelas, or is it the same? I have a nice picture of a foot with erysipelas. So we can make a distinction in these terms. So if we talk about erysipelas, you can say it's the more superficial infection of the upper dermis and subcutaneous dermis. And when you say about cellulitis, it's more lower in the dermis and subcutaneous tissue. So you can follow the arrows to the erysipelas and cellulitis, and then you can see the depth of it. So cellulitis can also be superficial. So sometimes these processes are coexisting, and you cannot really tell what is it cellulitis or erysipelas. So you can say erysipelas is a form of cellulitis. And in continental Europe, we can make the difference between cellulitis and erysipelas. When we talk to colleagues in the UK, they only use the word cellulitis. So for me, most of the time I use erysipelas. So now we have some issues, but no problem. I think I will use the term cellulitis more because it's easy to pronounce. Well, sometimes I mean also erysipelas. So the prevalence of cellulitis, we have a study, it's a little bit old, but there you can really see how many ambulatory visits of cellulitis in the US. In 1979, it was 4.6 million visits, and it really increases to 9.6 million visits in 2005. So you see that's really an increase of the occurrence of cellulitis. And if we go to the incidence rate, it will also increases from 17.3 to 35.5 per 1,000 people. So in all the hospitalizations for infectious diseases in the US, it's 10%. It's because of cellulitis. So it's a big part which has been treated in hospitals. So cellulitis and lymphedema, well, we know it's mostly because of the pathogens, the beta hemolytic streptococci and the staphylococci. It also occurs in children as in adults, so there's no really a big difference. You can have recurrent episodes, so not only one, but you can have like 5 a year. That's not so nice to have. But sometimes you don't have any cellulitis. I hope that is for someone is true. The prevalence is also in primary as in secondary lymphedema. So cellulitis you can have with both lymphedema. It can affect everywhere. So it can be the face, but most of the time we see it on the limb or on the arm. And it's normally it's unilateral, because when you have it both sides, then it could be something else. So we will talk about that. So you have 2 pictures with a child with erysipelas and erysipelas on her hand. There were 2 studies conducted by my colleague Dr. Damstra and my colleague Tanja Ručigaj, and they did lymphography with patients who had erysipelas to find out did they have a good working lymph system or not. And about 80% in both studies, they showed that people who had erysipelas had an impaired lymph system. And it's not only the affected, but also in a non-affected lymph. So that's a quite high number. So if you have erysipelas and you don't have lymphedema, maybe you should take a closer look at it and talk to your doctor. The most common bacteria in cellulitis is, as I mentioned before, the Streptococcus, and most of the time it's group A, but it could also be group C or G. And then you have the Staphylococcus aureus, and that's also common in eczema, like and other skin problems. There are also other bacteria who could cause cellulitis, but one of them is like Pseudomonas aeruginosa. So if we look at cellulitis, then the clinical features are most of the time it starts with flu-like symptoms. So you're shivering, you have nausea, fever, and it will come up very sudden and it's very rapid. And most of the time it starts with that. And after that, then you said, oh yes, my leg is hurting or my hand is hurting. And then you see the pain, the redness, the warmth, the swelling. And could also be like a rash. And sometimes there will be blistering because the swelling is very enormous, and skin breakdowns and erosions. Also the increase of lymphedema. We have some pictures here with about erysipelas or cellulitis. There are 2 on the face and on the legs. The first picture is with chronic venous insufficiency. Another pictures. On top you see the big blistering, and sometimes it's like hemorrhagic blisters. You can sometimes see the bluish purple color on the legs. It also can appear in breasts if there is edema in the breast. So how to diagnose cellulitis? Well, as a clinician, I have to look, I have to hear the patient, sometimes I have to feel the leg, and then we can say, yes, I think this is cellulitis. So there are no specific tests for cellulitis, it's all with the eye. And it depends how it looks on the person, and it varies between persons, how it looks. Sometimes with blisters, also without blisters. So if we do some testing, we can do a basic investigation, like a blood investigation. You see a leukocytosis, that is the white blood cell count is elevated. And then you have a protein, it's C-reactive protein. It's one who is quickly going up when there is an infection. We can also try to find the organism which is causing the cellulitis by blood culture if you're very ill, or swabs of pustules, erosions of wounds. But it's not always easy to find those bacteria if there are no entry wounds visible. Additional investigation could also do chest x-ray just to be sure it's not heart failure with edema on the legs, or a Doppler ultrasound to look for deep venous thrombosis or superficial one. Sometimes you can use MRI if you think about necrotic fasciitis. So let's see two other infections. So we could have folliculitis. The pictures on the top, they show the folliculitis. So you have the hair follicles, which there is an infection in, and you have pustules and redness around the hair follicles. It could hurt a little bit, but not so much. Sometimes there is itch. This is also caused by bacteria like the Staphylococcus aureus. Lymphangitis, it's the hand and the arm. You can have that with wounds on the hand, and it travels through the lymphatics and can go into the blood, so you can have sepsis. So you have to be early with treating with antibiotics. The last picture is of impetigo. This is one we see a lot in children. This is also because of the Staphylococcus aureus. And you have blisters and redness, and it's very contagious. Other skin conditions. Urticaria, it's a really itching skin condition where there is swelling and redness. It's really like plaques on the skin. It can be very small, it can be very large, and the itch is really on the front at the first point. And then we have secondary infected eczema. So this is a picture which is a lot of scratching or going on. It's all erosions. It can hurt, and it's really itchy also. Lipodermatosclerosis, it's because there is a long-standing edema in the legs, and it is giving changes because of inflammation, and it turns like sometimes brownish purple like change of the skin, and it's very hard and very tender if you touch it. Phlebolymphedema, so then there is edema because of the chronic venous insufficiency. And that also there you can have changes in skin color. So red legs. Yes, I have red legs, but what is it? Is it a disease, or is it just a sign? I think it's just a sign. And it is you can see it in different diseases, so it's not a diagnosis on itself. It's the color, it's changing because of the blood flow. So in the first picture we have again cellulitis. You can see really the redness very demarcated. And the second picture we have a post cellulitis, so we have still the redness, but it's more purplish. So also you can think about when we have edema in the legs for a long time because of stasis. Stasis, then you don't walk like an example, or you can have it also with a big obesity. So there's also, you can also have redness with it. The second picture is of also, I think, a cellulitis, but if you see the other leg, it's more purple, and this could be with venous insufficiency. More pictures with red legs. Here the first picture is with the superficial venous thrombosis. And then you have like a cord-like string on your leg. It's the vein which is thickened and hardened, and it's also tender if you touch it. So we need here a Doppler to see if there is clots. And the last picture is arterio-insufficient with a wound. Also, contact dermatitis is very red and itchy. And again, we have lipodermatosclerosis. Another two pictures. So in the left one, we have vasculitis. It's a sickness of the veins when they are very weak, and they will are a bigger penetration of the veins, and they leave this redness, red macules. And when you press, you don't see any difference. So they're really in the skin. And then there is an underlying illness could be there, and then give this vasculitis. Acute gout, I hope I pronounced it good. This is very, could really resemble cellulitis. It's all swelling and redness, and also very tender and painful. So you have to think about that when you have it's more on one side or of the feet. Then we have talk lymphedema rubra. There are different explanations, but I think it is the redness because of the vasodilatation of the in the tissue. So most of the time, if you elevate it, then it will get less. And we have a picture here when you can put in your finger and you get a dimple. So there is really edema in it, in this leg. And sometimes it is confused with cellulitis, but beware, this is most of the time both legs. If you have, oh, no, well, maybe it's not, sorry, that's confusing. You can have it on both sides. Let me say it like that. Okay, so entry points of bacteria. So the bacteria need to come in the skin to give the infection. So we have entry points. Sometimes it's really, really difficult to find it. Sometimes you need really a pinpoint entry to come in, and you don't even see it. And I hear that a lot from lymphedema patients. But when you have entry points like fungal infections, you should take care of it. Also, lymphectasia and lymphuria could be problems, skin folds and skin jumps also, and also the ulceration. So let us have a look. So the fungal infection, we have most of the time also moist, and this gives a better penetration for the bacteria to come in the skin. So it's in between the toes, and here you see also in the middle on the ankle. A lot of moist you see because it's the whitish color of the skin. So lymphectasia is because of dilatation of lymph vessels, and most of the time you see it on feet, but you can also see it on legs. And this is, the first picture is an example of the umbilical cord, I think it is to say. And you see this developing when there is an increase of edema. When you have leakage of the lymph fluid, it can come from the lymphectasia, but can also through the skin. And this is the lymph fluid is coming out. Sometimes it's whitish, sometimes it's clear. So the skin folds and the ski jumps. When there is more edema, you have more creases in your skin, and we especially see that with the feet. You can see the toes. Also the nails. Within primary lymphedema, you can see, especially at a younger age, but also in later on, the ski jump nails. And this is the upstanding toenail because of the edema under the nail. And sometimes you have also the infection under the nail. And that could also be because of fungi. So So this is also entry points for infection. Ulceration, yes, really not so nice picture, but just to show you, this is what we also see. So these wounds could be because of trauma, or it could be also from internal problems. And most of the time, a lot of bacteria are in the wounds. And sometimes you need a little bit more, and then you can get an infection. So how do we treat it? We use antibiotics. You can use oral antibiotics, but if it's really severe, you have sepsis, then you need intravenous antibiotic. Most of the people use amoxicillin, flucloxacillin, but there are also other options like cephalosporin, macrolides, or clindamycin. I would say the duration of the course would be at least 10 till 14 days. I think 7 days it will be too short, and then you will have a sooner recurrence of it. So 10 to 40 days, I would advise. Here we have another overview of other penicillins and other antibiotics, like erythromycin you can have, and you can also have a broader spectrum, like the amoxicillin with clavulanic acid. It's also OPSI. It really depends on your country, what is available. And yes, you should talk to your doctor about what you need, what is available for you. So next to the antibiotics, we need to do something about the compression. You can remove the compression temporarily if it's too painful, and it can hurt a lot. But we advise you to replace it as soon as possible if it's really tolerated, because sometimes this decompression gives the pain, give you less pain. So, and especially as you're mobilizing. So put it back on when it's possible. You can also, if you can wear your compression garments, you'll start with short stretch bandages to diminish the swelling. You can also consider zinc bandages of silver-based creams with it. What also you could also do is mark the swelling and the redness. Then you can see the progression or regression of the infection. You have to be sure there are no other skin condition, otherwise you have to manage also those problems. If you are very ill, you get the intravenous treatments, and you can be switched to oral if you're going better. So is there no fever anymore and the cellulitis had regressed, then you can turn to oral antibiotics. So during the infection, the increase is there of inflammatory cells and inflammatory mediators, and it gives the redness. There's also redness and warmth because of vasodilatation of the blood vessels. And there is an increase of swelling, edema, and all of this is causing pain, dolor. So use the compression to reduce the signs of infection. And after treatment, yes, there is also a little part to tell. Your skin will be a little bit itchy, you can flake, peel off. So maybe you can use some ointments to reduce the itch and scaling. So what are the risks of delaying the antibiotics? So you can get worse and can be very soon. So you can have sepsis, then a hospital admission is advised to have the intravenous antibiotics. And every episode of this cellulitis, it can damage the lymph vessels further. So that's why we don't want to see any cellulitis more, but yeah, sometimes it's really hard to get rid of it. There is an increase of continuous swelling. You can get ulcers of it. You can have more papillomatosis with every cellulitis episode. So we see a lot of recurrence of cellulitis in lymphedema, and it's really a significant problem, not only for the lymph vessels, but also for yourself, for your work, and for your family. And sometimes if it's really recurrent, is it really cellulitis? Could it also be something else? So maybe you have to look at that. If it is really cellulitis, and that could be the problem, then you have to consider prophylactic antibiotics. Also manage your skin and by skincare, and treat your lymphedema if it's not right. So we like to have a big reduce of volume if it's possible. So when we talk about prophylactic antibiotics, we talk about when we have 2 or more episodes in 1 year. This can differ between countries. So you have to talk about your own doctor or clinician who is treating your lymphedema. You can use the oral one of penicillin, or you can have it intramuscular every 4 weeks. There are more possibilities for this. In a study of my colleague Ručigaj, there is patient with lymphedema who have cellulitis, and when they were treated, the episodes of erysipelas were very low. So compression diminished frequency of erysipelas. So I think it's very important to mention this. So why are patients with lymphedema more at risk of cellulitis? Now, well, this is because of the lymph drainage which is changed, and the presence of the edema in the skin. And the lymph vessels will take care of the immune system. And when it's not working very good, then you have a decreased functioning of the immune system. So this is why you can have erysipelas more often in lymphedema. And the decreasing immune system, it's only affecting the affected leg or arm. It's not the whole immune system. Well, we have a little thing to mention. There are several forms of primary lymphedema who have problems with the immune system, but that's not for the whole group. So the risk factors of cellulitis. So having lymphedema is a risk factor. So not having controlled your lymphedema, as I talked before. If you have an earlier episode of erysipelas, athlete-free foot, if you have cracks or fissuring in your toes or your heels, if you have surgical wounds, trauma, radiotherapy, other skin problems like eczema, diabetes, you can also have more risk on cellulitis, the chronic venous insufficiency, and obesity. Obesity, when you have it, you can have more edema in your legs. And this also, together with inflammation, can give more risk on cellulitis. And when you have more obesity, it's also have more skin folds, and these could be entry points for bacteria. So, how can we reduce risk of cellulitis? So we would advise you to treat your lymphedema well and use your compression, and it should be really well-fitted compression. So if it's really loose, then you will not have lymphedema that's well controlled. Also the skin care. So take care of your skin by drying your feet well, just avoiding moisture. You can put creams and lotions when your compression is off, of course, to have a good skin care. Optimal weight, like I said, because of the obesity, it's not really good for the edema. And exercise. We would like to have it on daily basis. It's not always possible, but try to exercise. You will be your own pump. You will be on pump when you go on exercise. So, Pernille, thank you for this testimonial. So what she's saying, she has been through cellulitis several times and also in hospital. And she's saying, yes, I'm aware of the signs. So it's good to know what are the signs of cellulitis, so you can be on time with your antibiotics. And she says, yeah, I'm really listening to my body because I can feel the cellulitis coming, and then I know, yes, I have to go to the doctor and have my prescription of antibiotics. And she's always wearing her compression, and she takes care of her lymphedema and also for her skin to be in optimal condition. And she watches out for cuts and abrasions during daily activities. And also, she looks very active here. A healthy diet and exercise regularly. Thank you, Pernille, for sharing this. So, to take home message, I will say I would like you to take this home with this webinar. So be sure to know what the signs are of cellulitis, and when to go to the doctor. So do not delay treatment when you get cellulitis, and get it back into your compression as quickly as possible. And so you have to could reduce risk of aggravating the lymphedema. And also talk to your doctor if you're not sure there is erysipelas, or if you have more episodes of erysipelas than 2 times a year. So you can get prophylactic antibiotics. So I think we're through to the questions. Are there questions? So I will stop sharing my screen. We can go to the questions. Is that good? So are there questions? Or was it very clear?
There is a question from one who says, you said do not delay treatment. I've had cellulitis many times and I have been instructed by the hospital to have antibiotics at home, but my general practitioner is not so happy to prescribe it. What do you think of that? Is it important to have it at home?
Shall I answer? Okay, yes, I think it's really good to have it. If you know you have cellulitis and you had it before, then it's really good to have it at home, because then you know, then you can start early, so you don't have a delay in your treatment. So I think you should talk to your doctor again, that you know when you have to take it, and if you can talk to him. Yeah, and if I'm not sure, I will come to you. But if I'm really sure, you can take it and you have it at home, so you don't have delay. You don't have to go to hospital if you're too late.
So I think she's following up to say that's what she's doing, but how can she convince her general practitioner?
We don't have it on the website, do we? Well, maybe you can recommend something. We should put it on the website. Oh, maybe your doctor can see this webinar again. Yes, that's a good one. Please.
We also had a question previously about pumping, about using a pneumatic pump. When can a patient continue that kind of treatment, get back into it?
Yes, I don't think when you have the acute phase, then you should not do that. You can spread the bacteria around. So I would say only compression therapy, or in the very acute phase, nothing, just rest and antibiotics. And then if it's possible to put down the compression on, or the short stretch bandages. And then if it's getting better, so your fever is gone and you're getting you can get out of bed or moving again, then you can start, I think.
We also have often the question from patients who have been driving for a long time, and then after their drive, they get cellulitis. How is that possible?
Yes, that's also a good question. I think because of your sitting for a longer time, then your the outflow of the venous system is slowing down. So there is not so much, the flow is not so fast anymore, and that could result in an increase of swelling and edema, and that's why you have a bigger lymphatic congestion, and you are more prone to get the infection.
I think we have a follow-up question also here. Can manual lymphatic drainage be performed when there is active cellulitis? I feel after the first day it helps to resolve the cellulitis faster.
We do not advise that in the acute phase. If it's after the acute phase, I think you can use it.
I think there's a follow-up question regarding the general practitioner. It's I know this patient, she's from Denmark, and it's a problem I know in the Nordic communities, especially that the doctors do not like to leave antibiotics with the patients at home. So perhaps this is something we can follow up in our patient group afterwards, how we can support these messages. Yes. Yeah.
And you can only have one course of antibiotics. So there's 10 days and there's nothing more. So maybe that's a suggestion. That's not too many pills, but you have just one course at home and not more than that.
Okay, we have another question is, I have lymphedema in my left leg and I have now a fungi under my toenail that is treated with amorolfin, and it's taking years. Now I have seen a new treatment for nail fungi with laser. Could this be beneficial or dangerous for the lymphedema?
So when you use the laser, you heat up the nail, so it will damage the fungi, but the effect is not really like 50%. So I think you could have treated like that, but it's not working very well. Maybe Tanja, do you have any just suggestions on that?
I think that laser therapy for fungi on the nail, it's not good for patients with lymphedema, because this heat can damage not only those nails but the surrounding skin, and that can be entry point for the bacteria.
Mm-hmm. Thank you.
Thank you. Then somebody asked, what can I do about stomachache with antibiotics?
Yes. Yeah, that's not a good question to the dermatologist, I think. But yes, you can have some medicine for your stomach ache, but you be sure you have, if you're not able to hold it in the antibiotics, then you have to think about giving it also IV.
I think this might be something about that when you take antibiotics, sometimes you get a bit of constipation, perhaps. Yeah, it can also be an issue.
Also nausea.
Nausea, yeah.
Mm-hmm. More often is diarrhea, so you can eat yogurt.
Yeah, somebody also says yogurt and parenteral helps for the stomach ache in my case. Mm-hmm. We also have sometimes patients say they have no entry point, there's no wound, there's nothing to be seen, and they might have been in a stressful situation and they get cellulitis, and they see there's a pattern between stressful situations and cellulitis. What do you say about that?
Tanja, would you answer this?
Yes, when we are in stress, that's influence of our body, and maybe in that situation the infection will occur more often. So the stress can be a little bit some trigger factor for the lymphedema and for cellulitis. And if we don't see any big wound, we can have a little wounds, and that can be entry points for the bacteria.
So far, there are no more questions. Does anybody else have something to ask? Okay.
No. Okay.
I think that's...
Oh. And we will close up. Will you close up?
Well, I think I just also want to say that people are saying many thanks, that it was a nice and interesting session, and it was a good webinar. So I think thank you to everybody on the panel. Thank you for everybody from in the back scenes making this happening. And yeah, I thought it was great and very informative. So I'm very happy on behalf of the patient community.
Thank you. Okay. Yes. Thank you all.
Thank you.
Thank you to all.